It's Brandon Balser. I'm a nurse practitioner student at United States University. Currently, I'm in a clinical site at LES Health as a primary care provider. She's a nurse practitioner. She owns her own company. It's located in Southwest Florida, Naples in particular, which is where I'm blessed to be. Brief description of the case. We had a patient this week that was following up from a prior visit just a couple weeks ago. He presents with frequent loose stools for about 3 to 4 weeks with some occasional blood, no pain, no fever, no recent triggers. He did have a colonoscopy after we saw him, or after my preceptor saw him. Showed ulcerative pancolitis and iron deficiency anemia. He was started on mesalamine with some improvement, but nothing crazy. Why is this case meaningful? Well, the main thing is he denied the need for a colonoscopy or even a simple Cologuard for his entire history. He's had some past history, and his dad even died with an ostomy from colon cancer. He was new to my preceptor the last visit, which happened to be on a day I was not in the clinic, unfortunately. It was interesting to see someone super nice but so stubborn to receive pretty much any care of any kind. Excuse me, until he was on his last leg, so to speak. My preceptor said that she had recommended him to go to the hospital the visit prior due to his weakness and potential, dehydration. So I knew this was going to be a challenging case, and I was happy to dive into it further. The patient is a 77-year-old male, Caucasian, following up for evaluation of kind of chronic diarrhea. He's a reliable historian and came with his wife. His chief complaint was he's still having diarrhea in his blood, or diarrhea and some blood in his stool at times. HPI is he's a returning patient with intermittent diarrhea approximately 3 to 4 weeks ago. It's described as small, loose bowels, at least 7 times a day. It was up to over 10 times a day before this mesalamine. Occasional small streaks of blood in the stool. He reports the episodes are scattered throughout the day, obviously worsening after meals. He denied any abdominal pain at this time, but he did have some discomfort. There's no fever, no chills, no night sweats, no vomiting, nothing like that. Didn't say there's any dietary changes, no recent travel, and no new medications. He actually doesn't really take any medications except for Tylenol on rare occasions, aside from the mesalamine, which was prescribed by the GI doctor. Diarrhea was initially associated with some fatigue and mild dehydration. He is pretty adamant about keeping up on his electrolytes and drinking plenty of fluids throughout this whole course. He declined hospitalization the last visit, even though he was not doing the greatest, and it was recommended by the preceptor. He was referred to GI. The preceptor does have a local GI that she uses that gets people in really quickly, so it was pretty effective. He had never had one, like I said, never even a Cologuard, even though it was recommended to him by past providers. He started on mesalamine 4 times daily by the GI doctor. Reports improvement in frequency of stools. He was doing over 10, and now was at or around 7. He's lost maybe 10 pounds since the beginning of the year, but nothing since the past week and a half since the provider saw him initially. Past medical history doesn't include much. Some diarrhea and abdominal pain since the last time she saw him. He said he's only been in the hospital a few times ever. Once was an emergency appendectomy in his 30s. So, social history is he was a retired bar manager and sommelier, a wine expert, popular down here. Retirement communities. So tobacco never used, occasionally some wine with dinner, he says. Diet's pretty balanced, but higher in fiber and probably higher in sugar and processed stuff, he says. He does walk around the block, a couple miles each day on a typical day, and was riding his bike recently, but he's been pretty down, so he's not had the energy. Family history included his dad, who passed away at 80, colorectal cancer, and he did have a colostomy, I'm sorry. Mother's deceased at 85, history of osteoporosis and AFib. One brother at 74, type 2 diabetes. He's still healthy with no major medical issues other than the type 2 diabetes. Review of systems, pretty normal overall. The nice fever, chill, no sweats, mild fatigue, no recent weight loss since the last visit. No headaches, no visual changes, no chest pain, no palpitations, no dizziness, no cough, no weakness or dyspnea. Reports ongoing loose stools about 7 times a day, smaller in volume, occasionally with red streaks noted in stool. He denies any nausea or vomiting, or there's no distension, although the abdominal is mildly inflamed. You can tell it's a little distended, but pretty soft. He does have some generalized cramping at times. No dysuria, no issues with the GI or GU systems, no joint pain, no swelling, no stiffness, no weakness, outside of a little fatigue. Denies any anxiety, no depression. Pretty normal as far as, skin's in good condition, no medication allergies or allergies that he knows of. The abdomen, the vitals were all within normal, which was kind of surprising given that he's still probably a little bit dehydrated. I did notice maybe just the slightest bit of tinting. His abdomen was soft, non-tender, but it did seem full, no guarding with palpitation, and no noticeable inflammation of the spleen or the liver. He did have some rectal discomfort. I did take a look. I did have a small hemorrhoid, and it was a little, probably a history of bleeding there. Otherwise, pretty unremarkable. Recent labs, since he was in the preceptor, or did see the preceptor previously, he did have a low hemoglobin, hematocrit. His ferritin was low, his iron was low. He did show some inflammation with the higher elevated ESR and CRP. So showing active inflammation combined with the colonoscopy findings, which were ulcerative pancreatitis. Possible differential diagnosis that were considered colorectal cancer, considering his father. This is a high probability, high thought process. Although it's concerned with older adults, especially with blood in the stool, the colonoscopy did not show any findings. Infectious colitis, sometimes different bacteria can cause colitis, but nothing was noted. Again, ruled out by the colonoscopy. Ischemic colitis is another potential due to heart flow or blood flow or heart issues. Sometimes it could be some cardiovascular risk factors, but again, the colonoscopy shows different. Diverticulitis is always another consideration, but again, ruled out. So, resources that we use. American College of Gastroenterology has a good guideline that gives great evidence-based information on ulcerative colitis. My critical thinking process is, now that we had the lab work and the colonoscopy results, we can proceed with some treatment. Obviously the GI is going to handle on that side, but getting him a hydrocortisone suppository, hopefully help relieve some of the hemorrhoid discomfort. Referring him to a hematologist because his iron levels were pretty low. Obviously probably losing some blood. So maybe an iron infusion is a potential, so they're going to review that. Primary diagnosis is ulcerative pancreatitis, which is affecting the whole colon. Secondary diagnoses include iron deficiency anemia, external hemorrhoids, and generalized abdominal pain. There's no other diagnostic things right now, just because we just did labs recently. Medication-wise, going to continue the mesalamine, 800 milligrams 4 times a day. We did recommend over-the-counter hydrocortisone suppository, and he's even considering biologic therapy, depending on GI input. We did do a referral to hematology for the iron infusion, and like I said, possible Remicade or something like Tremfya, some of the biologics that we can use for autoimmune issues. Lifestyle changes were encouraged: hydration, obviously low residue diet during flare-ups, encouraged an iron-rich diet, things like lean meats and eggs, educated on signs of worsening anemia like fatigue, dizziness, shortness of breath, and provided dietary education and information on ulcerative colitis. Monitoring, obviously, we encourage the patient to watch for worsening bleeding, weight loss, increased frequency of stools. Call sooner or 911 if there's an emergency. Return to the clinic in a couple weeks after we have the hematology appointment and GI follow-up. Different resources that we can use. Obviously evidence-based practice. Mesalamine is a first line for mild to moderate ulcerative colitis. Remicade and other biologics have been shown effective for moderate to severe disease and in the elderly. Suppositories have been shown to reduce inflammation for potential hemorrhoid, calming down, so to speak. And iron infusions are usually preferred over iron supplements. He did have an intolerance to iron in the past orally, so that's where we went with that. Holistic approach, as far as Gene Watson goes, creating a healing environment is the most important to me. Having somebody that you can reach out to and speak with to help you heal is a big thing. Educating the patient and the spouse on the conditions and medications we use, provided printed materials on colitis, and we supported the patient's preference by avoiding the hospital. The patient did not want to go to the hospital.